Well, in this week's Cardiology Countdown, we have 3 papers that all deal with atrial fibrillation. First up, we have a look at whether genetics could help in risk prediction of stroke in atrial fibrillation. This was a study done from the Women's Health Study in over 20,000 women, where they first developed a risk score of stroke using age, weight, height, blood pressure, alcohol use, and smoking history, and got a C statistic of 0.71. Then they added some genetic risk factors that appeared to change slightly the C statistic, but they found did not change the net reclassification in terms of the risk of stroke. And so a bit of a disappointing risk score finding in terms of adding genetics, at least at this point, to predicting the stroke risk. Next up, we have a paper published in Circ that looks at the optimal INR when doing an AFib ablation. This was a retrospective look at 1,100 procedures where they looked at the INR on the day of the procedure. And fortunately, matching the overall target INR, they found the lowest risk of complications was when the INR was between 2 and 3. If it were below 2, the risk of complications was 10%. It was 5% between 2 and 3, and 12% above 3. The risk of tamponade was low, less than 1%, but didn't differ by INR category, meaning it was more of a mechanical issue overall. They did find that in patients who were also taking clopidogrel, the risk of complications was 3 times higher across the spectrum of the various INRs. And so while they call for further research, I think it does appear that an INR between 2 and 3 on the day of the procedure appears to be an optimal INR, at least for now. And the number 1 pick this week is a randomized trial published in JACC, albeit a small one in just 52 patients, comparing AFib ablation to rate control in patients with heart failure. And so they took patients with an EF of less than 35%, a history of heart failure, and compared ablation to a rate control strategy. Both strategies were achieved well in this small trial, where 96% had rate control achieved, and the procedure rate was 88% overall, a single procedure success rate of 68% in the ablation group. And they found that the primary endpoint, peak VO2, was significantly improved in the ablation arm as compared with the rate control group. This was not evident at 3 months, but was evident at 12 months. They also found at 12 months improvement in the Minnesota score and the BNP values, and a trend in the 6-minute walk test. And so as a small pilot study, I think a very nice demonstration that it appears that ablation does have hemodynamic benefits as compared with a rate control strategy. So for this week's Cardiology Countdown, I'm Chris Cannon.